great Japanese food around.
Right, so we'll wait for a couple of minutes. We'll just wait
Take
for
your
some
time,
more
yeah.
people to join. Yeah, we'll start then.
So what I've done is I've just put together a few issues which are relevant in the left main to all of us, and I'm not going to speak on any data. I'm not going to speak on any trials because everybody knows all that. But just how we have worked our way around it. Hi, Suresh, how are you?
Fine. I was continuing with where you stopped just now. We will have trial by Kirti, okay, on left main. Huh? Because from 2010, I think I shared some of them with you. From 2010 till now, I have about 600 left mains.
Wow.
And quite well documented. Huh?
Yeah.
So maybe we should get together, a few of us, and write something together. So we talk about it and we forget about it also.
So I think last time, I think you were committed to submit your data to the Asia Tech somewhere where you were, so you were not sure about something. So we should have a registry where we can put in everything, and it could be such a beautiful registry because we have so much data.
Clearly, one area which is out of surgeons' world now.
I think so.
Nobody sends left main to surgery just because it is left main. They would try to think whether we can address that left main, and I think that's the correct way to go.
I think so. It just made a very intuitive sense that left main should be in the angioplaster's domain because it is so close to the ostium and you don't have to work deep down in the ostium, which is treacherous. It's easier to work closer to your guide catheter.
Yeah, I think the issue was very important when if you get an ISR to left main, it was a big issue. The patient would die suddenly and such issue.
Yeah.
But I think things have changed so much with good performance of the stent, as well as good performance of the cardiologist.
I guess
I think both these are very important factors in getting left main into angioplasty field.
And at least some of us who have been doing this for, say, these last 20 years or so, I think we've been through those 5-year patches where we have seen ourselves doing things differently than we did 5 years ago. And I think that is the most important evolution in this field, really.
I think nobody refers it to a surgeon these days just because it is left main. Earlier, a decade back, I think left main was one of the surgical reference indication. So I think that is going away clearly. And many are doing left mains very comfortably.
Also, Suresh, I think the plethora of devices and tools that we've got into our cath lab now is so encompassing to most it because heavily calcified, deep calcium, even if you did rotameter, it was not expandable. Now that number of people who you cannot expand has gone down. So you can almost optimally deploy a very large number of stents. So
this big diameter stent also is a great help. Pushing a 4.0 stent to 5.5 and pushing a 5 stent to 5.5. I think there is a clear difference.
And we're waiting for
long-term behavior. Yes. I would feel like Giants are still stuck at 4.0 as their largest diameter stent. So, I hope this is not a meeting by Giants.
No, it's not.
But
it is so refreshing to have a non-industry meeting, I'm telling you.
Yeah.
Yeah.
No, this is an unbiased meeting. I think this is a very good platform Dr. Sethi and Dr. Rahul Patil have brought in. That it was always sponsored by a pharma. So we can talk what we like in terms of stents, in terms of bypass, and so on.
Awesome.
Right. So should we begin? I think we have enough people who have joined in. Dr. Hiramat, should we begin?
Yeah, go ahead.
Yeah. So good evening, friends, and I welcome you all to this month's clinical meeting. Our topic of discussion today is left main interventions. As we all know, that left main disease is no longer a surgeon's domain. Rapid advances in DES platforms and optimal drug elution profiles, with further advances in pharmacotherapy involving potent P2Y12 inhibitors, combined with the utilization of intracoronary imaging and assessment for planning of procedures and optimization, has transformed PCI into a successful alternative to CABG. To shed light on this very important topic, we have an expert in Dr. Kirti Punamia, who will be talking to us today about the approach and technique of left main interventions and how it deals with complications. And on behalf of CSI-Pune, I extend a warm welcome to Dr. Kirti Punamia. He is currently the consultant interventional cardiologist at the Bridge Candy Hospital and Saifi Hospital, Bombay. He is a graduate of Sion Hospital and later on did his fellowship in coronary interventions at Melbourne and then in the United States of America. He was awarded the Dr. Raj Gopalan Award for the best paper in electrocardiology in 1990. He has been a guest faculty and has delivered multiple invited lectures on various interventional topics all across the world. He has conducted live workshops both nationally as well as internationally on CT, left main interventions, and management of calcified lesions. He is an international proctor of ROTA, IVUS, and OCT. It is indeed a privilege to have Kirti with us today. The moderator for today's session is Dr. M.S. Hiramat, who is the doyen of interventional cardiology in this part of the world. I now hand over to Dr. Hiramat to carry on with the proceedings and invite Dr. Punamia for his talk.
Good evening, everybody. Kirti, it's a great pleasure to have you with us for left main especially. I know you can talk on many individual components of angioplasty, especially things like IVUS, rotablator, and so on. But left main is one area where people like to go, yet something stops them, something sort of prevents them from getting into left main. And sometimes it's the hardware issue, sometimes it's the cost issue, sometimes it's the risk involved, and so on. So on this background, I think the left main is one area which is slipping out of the surgeon's field, and many cardiologists are getting into left main. The issue is left main, when we do, at the distal end, we have two important branches, and that's LAD and circumflex. And how would you address the distality of the left main stent? So I think we are all very keen, very eager to listen to you as to how you have done these left main issues over the last maybe couple of decades, and have a huge experience in dealing with you. So Kirti, we won't take more time. Go ahead. We ask questions only in the end, or we can stop you.
I think you should stop me wherever you think. Let this be a dialogue rather than me just rattling over. I think.
Dr. Rahul, how are you going to organize this? I mean, there should be no two people asking question at the same time. So, is there any way to organize? Oh, you're on mute, Rahul.
So, what I feel is suddenly someone interrupting in between will be very odd. So rather than doing that, it will be wise to put some message in the chat box, and we can ask this question during the course of presentation.
Okay. Whatever, and I'll be happy to stop at any point if there's anything that you want.
You know what? Taking questions like Kirti, you present say 7-8 cases in a row, and
then I can
then
start.
ask you a question on case one.
Yes.
Right.
That's a little bit odd. I mean, for the listeners as well as for you to answer that. You might be able to remember, but people who are listening to you just once may not remember your first case when you have presented 8th or 10th case, you know. So maybe if you can pause a little bit after every case, or I don't know
Sure.
how.
Whichever way, if there's anything, don't worry about the interruption. I think this has to be a dialogue, and the question is best asked when it arises. Otherwise, we'll lose the relevance of the
Yeah,
question.
that's what I'm saying.
Right.
So, Rahul, can you make arrangements so that people can ask questions at the end of the case? We won't interrupt, Kirti, your presentation as such, but
So,
when you give a pause at the end of every case, people could ask questions.
Perfect.
right, sir. Right, sir.
So how do
We'll do
they
that.
do it? Unmute
So,
and ask
yes, sir,
questions?
unmute and ask the question.
Okay.
Excellent.
Yes, sir.
So, Kirti, you remember this as you go on, huh?
Of course. So first of all, Sirish, thank you so much. I must thank Makle, Sirish, Rahul, and all of you at Pune to have me over. It's a great honor for me to speak to all of you, and especially with people who I revere on this group, like Sirish, who's been like a great friend and a leader in a sorts, leading us as well at many times. I am very humbly going to kind of talk about my journey through this, which has been over the last 25 years, and how we've slowly grown in the left main space, and how we've evolved. What are the things that have changed in our practices and why they changed in our practices? One of the things that we often rely on is clinical trials to let us change a practice. But I think our own experiences and our own intuitiveness about certain issues should govern our practice patterns. And I think that is an important key message that I wish to kind of bring forth in this talk. Can everybody see my slides at the moment? Yeah.
Yeah.
Okay, great. So I'll start. So we're talking about strategies, and we'll start uh, with the with the very basics. It all started for all our programs many years ago because we did left mains because surgery was not an option, and surgeons threw cases at us which they didn't want to take, like severe organ dysfunction, especially renal, people with COPDs with FEV1s of less than 1, elderly patients who are frail, stroke, susceptibility to infection, acute myocardial infarction. Frailty was a very big issue, which was not discussed earlier, but indirectly, a lot of surgeons just did not want to touch those frail patients. Immunocompromised, recent sepsis, dermatological issues, and of course, family sometimes declined consent to surgery for various reasons. And then the left mains fell into the lap of an interventional cardiologist. And it all started like this many years ago. It also, recent surgeries which went wrong, grafts closed, were the other reasons why we had to, like a year ago, the patient had a surgery and then we had to intervene left main space. I think those were the reasons why a lot of the interventional cardiologists started getting into this space reluctantly initially, but soon realized that it is not such a reluctant space to be in, and it should be something that has to be changing gears as far as who's going to dictate the philosophies in this space. So the first question that we really need to have is, do I have the skill set? Because the skill set is very important, and this comes from a very important paper from China, which says that the more experience the person has in the space of the left main, his mortality, cardiovascular complications is going to be lower than people who do less left mains the year around. This was also voiced similarly from the British Interventional Council BCIS data, which came in with 130,000 patients, where they looked at the left main space over the last 15 years. And one thing that stood out was people who did left mains more often, like more than 25 left mains a year, did better than people who did less than 5 left mains a year. And I think this is important, very important. So the question is, one of the important things that came about is imaging in the left main, and of course the tools and the way we use it. And these are the very simple questions that come to my mind into what are the questions and what are the answers I seek from an imaging is stent sizing, landing zone, strategy. But how do we actually put all this into perspective, and what are the principles that govern, or what is the drawing board on a drawing board? What do you put on a drawing board to charter a path as to how you're going to take the left main angioplasty forward? So it's a very common practice in my cath lab that I draw the entire left main as a cartoon sketch on a whiteboard. And I tell my technicians that this is our plan, and then we execute the plan to the T. And of course, we have room to negotiate. We need room to make adjustments and a difference from our plan or deviate from our plan. So what are we looking for? First of all, we need to define what we need to get to. So it is a architecture in reverse where you want to know what your result is going to be. So how are you going to get to that result, and what does it take for you to get to that result is the way we plan this. Okay, so may I request everyone to kind of turn off their mic so that then if you have a question, just press the space bar. Otherwise, you just interrupt. Yeah. So I think what are you looking for in the left main space? I think when you look at the left main and we take a complex bifurcation lesion, such as this, which is in this cartoon, I think for the most important, everybody wants a pre-PCI imaging. That means before you start and do anything, let's get the imaging in and let us find out what we're dealing with. But many a times this is not possible, particularly in the calcified group, which is around almost 40. If you look at various trials, they go from 35% to 45% of the left mains are moderately calcified, where sometimes you may not be able to put in your imaging catheter. And therefore, pre-PCI imaging may not be possible in those patients, but at least pre-stenting, before you put your first stent in, and imaging is absolutely mandated in the left main space as far as I'm concerned, because that will tell you so many stories about whether you're prepared or not, and whether your size is wrong or whether your size is right, and many other issues. So I think from the pre-PCI, pre-imaging, we should talk about pre-stent imaging. I think we should do that. And the first thing that imaging is going to do is to confirm what we think is the angiographic landmarks for stent edges, should confirm if they match with the IVUS landing zones as well. So a landing zone is a stable plaque, either fibrous or fibrous plaque with a little bit of calcium, maybe non-protruding calcium, but it would have a plaque burden of less than 50%. And that makes a great landing zone for the edge of the stent. And when you look at the landing zones, you have the landing zone in the proximal part of the left main. You'll have a landing zone in the LAD at some point. It could either be close to the ostium or it could be further down, or the circumflex artery. And you need to identify what in this lesion, which is your landing space, and what is that region which gives you that room to flex in terms of where you can land the stent. And of course, it is these landing zones, the brown areas, which are going to determine the size of your stent. The size of your stent is not going to be determined by the core image where the lesion is most relevant, but it is going to be decided by the lesion, by the site where the lesion is least relevant. And the plain simple reason why we don't take these lesions, which have a very high significant volume of plaque, is because the reference vessel diameter in these areas is very difficult to judge. One, because if there's calcium, it may be difficult to see the elastic lamina in the media. And two, because of this plaque, there is going to be some positive vascular remodeling, which is going to completely disorient your size concept of the reference vessel size. So two reasons why we should not take the size of the heavily plaqued area and go to areas which are less than 50% to see what the size of the artery is. The question is, what if the landing zone is now, say, 30 millimeters beyond the ostium in the LAD? So when there is a landing zone which is 30 millimeters downstream, I think the most important part is that for every 10 millimeters that you travel in an artery, especially something like the LAD, you will have a 0.3 millimeter increment as you come proximally in your reference vessel diameter. And this is, you have multiple studies which have actually looked at intravascular ultrasound of normal arteries and kind of come on to this conclusion. It goes back to 1975 with Lance Gould's paper that if LAD reaches the apex, then it's most likely going to be at least 3.5 to 4 millimeters at the origin. So I think with that, we should be able to come to a fair conclusion of what the size of the artery is going to be at various levels. And I think that geographical map of the lay of the land is very important. Once you do that, I think the rest of the images are the core images, which I call the core images, which is the seat or the heart of the lesion. And these core images are where we need to concentrate on the lesion characteristics. And here is when you're going to tell what is the stent strategy. Are we using a single stent? Is it going to be a two-stent strategy? Is it going to allow two stents or single stents, or how and what? And what device you're going to use to be able to have an optimal expansion of the stent in this area? Because eventually it may be that making sure that you don't distort or deform your stent proximally and you don't longitudinally or cross-sectionally deform the stent at either end of the Y here. The most important determinant of long-term results is going to be how well you expand the origin of the LAD, the circumflex, and your confluence with your distal left main. And therefore, now we get on to, now we are ready to understand, and we will get to that slide in a bit. But before we get to that, one of the most important key images that I look at when I look at, say, we want to stent from the left main to the LAD as a single stent strategy, I often see operators taking an IVUS image pullback from the LAD back to the left main. And that is great because that is the obvious thing to do. But what is the most important thing that is going to influence this decision, whether it's correct or not, is going to be the pullback from the artery that you're not going to stent, which is the circumflex. And this orange area, which is defined as a 5 millimeters from the ostium of the circumflex, or you can say from the carina or from the ostium bent of the circumflex artery, 5 millimeters downstream, is going to be the distribution of plaque over there, the relationship to the branch ostium. And I'm going to try and show you why these IVUS images are probably the most important images in being sure about a provisional single stent strategy that is going to remain single as you go along the case. The important part of it is that when you actually do intravascular imaging, the one thing that we need to factor specifically as you come along the left main into the circumflex into the left main is that because the wire is going to go and take a bias on the lesser curvature, you cannot get a true transection in any plane of the ostium of the circumflex. And remember that you just cannot get a true transaction of the circumflex artery, whatever technology you use. It is all, it is always going to be a bevel. So we need to make sure that we look at not one plane, but a few planes to understand what sizes are. So to understand the size of the circumflex artery, don't rely on the image at the ostium. Go 5 millimeters inside and you will know the circumflex size, because that's when you see a transection. And the section over here at the true ostium, what we call as the ostium, where we see the opening of the os, is going to be more to decide what kind of device you're going to use, because the wire bias, its association to calcium, its association to plaque, its relevance to the ostium of the LAD, because for me, these two windows of ostium are sitting close to each other. And what you do in one of these windows is going to grossly affect the other window. And that is the important part of this image, the ostial circumflex image. I hope that that is very clear, because this is a very important thing which I see a lot of people probably make a mistake or do not account for, is the oblique nature of the sections at the ostium of the circumflex. Let's go into a case now. Let's dive into a very simple kind of a case. This is a straightforward left main which tapers down quite drastically into an LAD, which is quite diseased for some time. And what appears like the ostium of the circumflex might be compromised to some extent. The question is what and how much. So here, as we take a section, we look at the cross sections at various lengths, and we go all the way into the LAD. And in this patient, we went 51 millimeters from the landing zone in the ostium of the left main. We went out 51 millimeters downstream was a landing zone in the LAD. So one most important thing is we have to go far down, because the worst outcome is in when you put in an edge of your stent in areas which have a plaque burden of more than 50%, then your restenosis rate and ischemic complication rates go up. So we found a plaque burden of less than 50%, and we found a stable looking plaque, which is a good recipient of the edge of your stent, 51 millimeters downstream. The rest is okay. You need to account for the branches that come out, the diagonals, and of course the ostium of the circumflex. But the decisive image, which is going to tell me whether a single stent strategy is going to work in this, is the circumflex ostium pullback. And the way you see it is you look at this image, which is at the carina. This is an oblique cut, as I showed you in the past. I mean, this is going to be an oblique cut like this. And you can see that this is where the left anterior descending artery is. And what I see in this is a fairly large left circumflex ostium where the diameter is at least 3.5. So this area is almost like around more than 7.5 millimeters square area, which is good. And if I see the plaque is all away from the carinal border of this circumflex. When you have plaque which is distributed in a way that is away from this and a large area with a less than 50% plaque burden in a large circumflex artery, then this circumflex artery is very unlikely to be compromised with your angioplasty program, which involves a stent from the left main into the LAD. And this is important. So here, when I see an image like this, I don't even worry about the circumflex. We may put in a wire always to make sure that you don't lose it, because in these PCIs, even a transient loss of a branch is a mortality invitation. So we cannot afford to do that. So once we prepare the lesion, you put in your first stent from left main to the LAD, and that is what I do. And then I do a pot, and then I put in my downstream stent, cover the whole area, optimize it, and then do an IVUS. It's very important that after you put in your first stent, it is before you put in your second stent into the artery, whichever. I mean, I prefer to put the proximal stent first and then the distal, but I know that a lot of people want to put the distal first and then come proximally. It's a matter of practice, but I just prefer doing it this way. Is because I want to secure my left main and the proximal LAD and this bifurcation as quickly as possible and not wait for it to develop thrombus by dissection planes and things. But before I go and put in my second stent, it is important to optimize this with a pot. And even after the pot is done, do an IVUS pullback. And in this particular case, we found that in spite of everything, there was a part of the left main where the stent was still malopposed or not expanded completely. And for me, this is a recipe to a disaster, especially if it is going to be a two-stent strategy at any stage. And so optimizing this left main stent is important before you put your second stent in. So here we took a larger balloon and opposed it to the left main. And once we had secured this entire left main, there is no reason why, or there is no problem with putting your long second stent through this area, and you should have no trouble. And then it's just a matter of optimizing the LAD to a maximum to get your best MSAs downstream. This is our final result with a single stent from a left main into the LAD and a further downstream stent into the LAD to the landing zone. Now, why did I ever think that I need to put my proximal stent first? The reason being that most of the people the teaching is that when we are looking at a bifurcation cross point like this, we choose our stent based on what we are looking in the landing zone distally, a stent size. Now, say the landing zone is, say, 20 or 30 millimeters downstream, or 20 millimeters downstream. And you are going to say that that is around 3 or 3.25 millimeters. So let me take a 3 millimeter stent or 3.5 millimeter stent and then extend it all the way to the left main, and I'll do a pot. The problem is that in most times you may not have a problem, but inadvertently, what happens is you have dilated the stent, but the proximal stent in the left main is still malapposed. And because it is malapposed, now you want to get your pot balloon to do a pot, and these pot balloons are typically NC balloons, or they're short balloons, or they're large bulky balloons because it's a larger left main. And as these balloons enter these left main, it distorts one edge of the stent, and sometimes it is inadvertent. You don't even see it angiographically. And then you dilate it, and when you look at the IVUS, you will see some struts scattered over here. But no imaging technology is perfect to recognize longitudinal deformation unless you see clear stacking of struts. That means one strut over the other strut. Unless you see stacking or a clear gap over a period of time, it's very difficult to recognize this. In fact, it is more recognizable by dense fluoroscopy or by stent boost. And I think that is the key over here. What I do instead is I choose to take a larger type stent, which goes more to the left main size, like a 4 or 4.5, and then deploy it slowly into the left anterior descending artery, not over a very long length, but just 5 to 10 millimeters into that left main. And the idea is to deploy this stent at 6 or 7, because if this left main is large at 6 or 7, this stent is very likely to oppose or go close to the wall, which gives me a better chance of putting a roomier balloon over here to get a pot done at a low pressure. And then you can have the LAD stent expanded at high pressure to the size of where you estimate your LAD size was based on your distal IVUS measurements and then your correction for the length or the branches that exit. I know there will be differences on this, but would anyone like to ask anything about this before I go ahead? Because this is a...
Yeah, Kirti, we always put the distal stent first and proximal stent later or next, and get a stent, proximal stent to overlap the back end of the deployed distal stent.
Yeah.
You are trying to say that you deploy the proximal stent first.
Yes.
And, you know, many times the wire mesh may not allow metal to metal rubbing very easily, and the next stent may not go, especially if you're bringing this stent to the ostium of left main, which I think you and I like to do it most of the time. Like short left main, you will always cover the ostium. And that is why I would probably feel that you put the distal one first and then the proximal one.
So we've been through this many times, and I will show you some examples of how we have done it in many, but this is something that has prevented me from distorting the left main stent. And I think this is a very, very important thing, especially when the left main is disease-free. When the left main has disease and it has a significant narrowing, even when you open the stent to 3 millimeters, you're almost opposing it. All you need to do is now expand it and dig it into the plaque. And that does not make a difference at all, because the stents which are malopposed and floating like this are easy to deform, whereas stents which are opposed to the wall are very difficult to deform. And that is the most important tenet of this little exercise and this slide. But let's go ahead and I'll show you some other examples.
No,
now
you also need to tell us the cross-sectional area that you get after you deploy the stent. Is going to be very important. So if you deploy a stent which is touching the vessel wall, but not giving a big cross-sectional area, that's not very nice.
Absolutely. So I am going to, we're going to come to those images and all that as we go along this, as we build this story around.
Okay.
So port, we talk about port, and it is essential and needs to be done systematically. Idea is to achieve a complete apposition along the shaft of the left main and make sure that your struts are opposing the left main at every millimeter correctly, at the same time, not over expanding it and not damaging the media. There are two important lessons that we've learned as far as port is concerned. It should be the concluding step of the left main PCI, because when you are putting your guide catheters in and out inadvertently, you can do things to the proximal. And if you end with the port, once you've done your port, your final port, it is the best time to de-instrument the left main. And if you have to take further pictures, it is better to come back with a narrow diagnostic catheter and then document your final picture if required. And it should be the concluding step. Now, this is a case that I want to show you. Here we did a left main and we did a circumflex angioplasty with the left main was distally involved. And so we put in a stent from the circumflex artery downstream, came to the proximal circumflex, and then landed it into the left main. Now, all you can see is that you can see that my left main over here, the port is not done well. This was, even after doing a port, you can see that my distal left main confluence is still underdone. It is smaller than the circumflex ostium as far as area is concerned. And the reason is because we look at the distal edges, but we don't look at the confluence very carefully in the left main. And particularly when you're coming from the circumflex upwards, this area is missed. And I can tell you that every time I've gone and looked back recently, I've realized that what I used to think was a great result, I've had to revise that result. And how do I revise this result? Because there are two things happening here. This is a simple, you need a bigger balloon, and you can go at a bigger balloon at a low pressure and you can oppose this stent. This is just a matter of apposition of the stent, and you can do that. But getting this distal length, distal confluence right, means that you've got to correctly position your port balloon. So you need to understand your post-dilatation balloons well in terms of where their shoulders are. And you need to identify a very good angiographic view to make sure you're right before the carina, but you're not beyond it, so that you don't shift your carina in trying to do the port. And I think that is an important lesson. So now let's look at an animation I've created. Typically, when we look at these and when we look at these high pressure balloons and we do a port, we try to keep the thing before the carina, and then there's a shoulder which goes down there. And so we can take this a little further. But when these stiff balloons move up, what they happen in a large roomy left main is that these balloons can, and when there's plaque, they will actually align it themselves in the way the wire is to the end, that yes, the stent struts will fall in a straight line along the balloon, but sometimes the distal part of the confluence is not treated, is not opposed well. And so you'll see a lot of unopposed struts. And when you take a pullback, this entire thing is the of the LAD where the apposition has not happened, whereas the actual LAD ostium is right up here. So how do we get these struts up to this point? So what I do is, when I finish this port in a very large roomy left main, I take this wire out and I put in another wire, and I take that same balloon and I do a port of the left main without crossing the struts. I just port the left main here, so I can get a proper apposition, because it reorients the balloon, because when my wire is in the LAD, the whole orientation changes. And I've often seen that this simple thing of this sort, even at the same pressure, you don't have to go at very high pressures, is enough to reposition your struts in a way that they now oppose the left main, even going into, this is even for a single stent strategy I'm talking about. In a two stent strategy, anyway, we are going to do a kissing balloon, and therefore this kind of doesn't resolve. Now, a lot of people have said that we could do a kiss in the side branch, which seems to be the same issue, which is corrected by doing a kiss and then a port again. But the problem with that is, when you start putting these balloons into the left, into your branch, and if there is a plaque, even if you do a low pressure, we do not know whether you are causing some kind of a damage to that plaque, which may incite a restenosis or something. I think a routine side branch cross at this present time, and we'll discuss that a little bit, is still out there. We don't know the real answer to that in a single stent strategy. So this is just one way to correct that little malposition in the left main. The question is, a lot of times we have anatomies like this, which is complex, where it is a 1-1-1, where the ostium of the circumflex is involved. But as in this case, I mean, it is calcified. So we did a rotational atherectomy to it, and we went with a 1.75 burr as well. And once we did that, you can see that the landing zone in the LAD is a clear 3.5 millimeter lumen. And here we have almost like a 4.25 millimeter lumen, so a 4.2 millimeter lumen over here. So lumen to lumen, we have a 4.2 to 3.5, but we have this concentric calcium, and this calcium, which is less than 180 degrees with a fibrous plaque on the other side, best is treated either with an NC balloon, or in my practice, sometimes I use a cutting balloon because it's a short balloon. You can get precise dilatations at precise points, and you don't have slippage of that balloon. So that is my preferred balloon. And then I think that a 3.5 cutting balloon would be a fair thing to do for this. But what is important is the ostium of the circumflex. The ostium of the circumflex is non-calcified. It is tight, but this disease did not extend to beyond exactly 2 or 3 millimeters. So for me, here I'm not going to put a stent in spite of that circumflex ostium being an issue. I took a 3.5 flextome into the LAD, cut the distal left main, and I took a 3.0 flextome, just put the mouth of the flextome into the left main, into the circumflex artery, did a 10 atmosphere dilatation to a complete expansion. And then all I did after that was a single stent, which is across the left main. And we have long-term data on this, where these patients are doing quite well in our limited practice. Now we've got a fair amount of patients where we've done this. Now, people may ask me, is dilating with a NC balloon not good enough? I think that advantages of the cutting balloon in this, or a blade dependent balloon, is that the blade dependent balloon doesn't shatter the artery. It has precise cuts into it. The metal areas give you, the energy is focused on those 3 areas. So the trauma is not generalized, and you don't see a dissection as such. You will see linear tears in the artery, which is the way angioplasty works. And you can precisely position your stent at a balloon at a particular spot, and you will expect that it will not jump out of the way, it will not slip. And therefore, these are the reasons why I think the cutting balloon serves the best purpose over here, and sometimes in some diagonal branches as well. And we can get away with some of these lesions, and especially like this, soft lesions, which are very, very discrete, less than 2-3 millimeters long, can easily be treated by not having to put in a side branch stent at all. In my earlier practice, I didn't even put drug-eluting balloons in this. But now, I mean, for some case, I mean, if I were to do it again, one may say, okay, fine, let's do a drug-eluting balloon. But I think we would have to find out if that data really favors. We don't have a randomized control trial to kind of say one is better than the other in the sense. Taking a little more complex path, and I think this is a very calcified lesion, and you can see that it extends. There is a lesion over here, which is tight, as well as a lesion downstream in the circumflex. The LAD seems okay. So we do a rotational atherectomy. We get the rotational atherectomy out of the way. And then the question is, what do we look at in terms of data? And I think the first is look at the artery, which is least diseased. And you see that the LAD is okay. It's got stable plaque all around, and this is from our OptiCross, early OptiCross days. This was not the OptiCross 6, but the actual OptiCross iris images. And you can see it's 6.1, 5.3, and the ostium is 6.5. It's a fairly stable looking plaque over here, and you can see the circ looking right into there. The circ itself is proximal, is very calcific. You can see that we've got a dissection plane after doing a balloon dilatation with a 3O balloon after a rotational atherectomy. And the left main, here's the left main. This is the left main distal, and this is the left main proximal, very close to the ostium. Now, when you see images like this, there is no question that you will have to extend your stent all the way to the origin or the ostium of the left main, because you can't leave such a shagged little plaque at the edge of your stent. Even though angiographically some might be tempted to leave it at the shaft, imaging told us that this will have to be extended all the way to the origin. So now, given this origin over here to the LAD, with no carina is quite clean, and this kind of an angle, I decided to put in a single stent across, and this was my stent strategy. So we completed our stent strategy. So we went into the details, and we said that, okay, from the ostium of the left main, the bifurcation point at the circumflex origin is 14 millimeters away. So I need 14 millimeters of stent length in the left main from the carina. And then, of course, I will have to deep dive into the circumflex. So when I look at this, what I did was I took a 4 by 18 onyx. I positioned it at the origin, and I just put it into the origin of the circumflex, and I deployed it at low pressure. My next thing was to do a pot. And then once I've done a pot, you can see I've taken a 3O balloon. And this also allows me to have a minimal overlap. When you do the distal first and the proximal later, the overlap segment is not in your control. You have to do with what you do. But when you do it the other way around, you will see that you can control your overlap patterns, and these overlaps can be well controlled. This was a final result. Now, how does this patient do going forward? This patient, this is our final areas. You can see the circumflex had a 6.8, 8.3. We had a circumflex ostium of 8.9, and we had a 12.8 in the left main. And this is not, it is not uncommon to see this kind of not a circular pattern in the left main when you have this eccentric pattern of calcium. You can see this eccentric calcification, which is protruding. In a large artery, we don't have a great technology in India at this present time. Maybe as we go forward, orbital atherectomy might be able to shave this off and get you a little more circular picture. But these protruding calciums, which are in single quadrant or two quadrants, that is eccentric, are difficult to get a circular left main. But if you can get an MSA, which is 12.8, without deforming the stent, then I think you're doing a good job. And I wouldn't go on to make it circular. 4 years later, this patient had angina, and his left main to circumflex stent is widely patent. Now the question is, how did we prepare for that? Because this was 6.0 area, as I showed you before. The question is, did I at that time open the struts of the ostium of the LAD? I mean, the struts across the ostium of the LAD? I did not. And as a practice, I don't. And so what do we find? And this is the OCT image of that pullback. And you can see that the struts are quite well over here. I'm going to show it to you closely. Let me show you some images again. See, 2 years later, and these images that are lovely images. So this is the calcified LED. This is the iris catheter coming from the LED to the left main, and you will see that this is my primary iris catheter, which has gone in, and it comes in. As you come in, you will see the ostium of the circle. This is, you're right there, you're in the LED, you're coming into the left main space, and this is the LED, and this is the origin of these LED, and you can see the struts are on both the sides. These are the struts which we did not move out from the origin of the LED. And now as I come back forward, I am going to come into the left main, looking over here. And it's okay. There was no issue with my access into the LED at all. And let us look at the OCT again for that matter. Okay, so anyway, we completed this angioplasty, and it hardly impeded my flow, and it was amazing. So what I did was I extended my stent into the left main, and this was a stent already there from there. So this almost behaved like a deferred culotte technique. That means you did one arm of the culotte 4 years ago, you've done the second arm of the culotte 4 years later. So you made a culotte, and then you still, now you have struts across the left main left circumflex artery. And I didn't think that there was any need to really destroy or actually touch that circumflex artery. Let us look at these two images again. And here is the OCT going from the circumflex back into the left main. And you can see my struts are pretty clean. They're gathered, and they're doing okay. It is only when you go to the edges of the struts, far edges towards the wall, that you will see some tissue on them. But none of these tissues are restrictive at all. And I have many such, fair amount of such images. And of course, the IBIS I showed you. So do I always recross and in a single stent strategy, recross and do a balloon dilatation in the side branch? Yes, if it is flow restricting and suboptimal. If the downstream PCI is expected in the future, for me is not a very strong indication at all, unless the access into the artery is very difficult, in which case you need to make sure that your access remains good if you're expecting something will go down. But the real answer is no one really knows the right answer as to what needs to be done here. Everything is anecdotal, and it may vary from one operator to another and one practice to another. And nobody is right or wrong, but I think most of us will learn as we go along what is probably an in-between. I routinely do not do this. But look at this case, for example. Now, this case is a left main, which we did in a young patient. We did it not so long ago, around 4 months ago. Patient had a right tight, which we fixed. We ended up, we had this left main, which was to be done. The ostium of the circumflex didn't look too diseased. But once we had we'd done a laser through this with a 1.4, and then we put in a cutting balloon and then put in a stent across. And we put in a stent across, this is what we found. That angiograph, can you see the little circumflex, which looks a little compromised? When this circumflex looks a little compromised like this, we look at the IBIS images. And when we look at this IBIS images, you can see that there is that compromised strut. There are struts around right over here at the narrowed circumflex origin. So here I dip in a balloon, which is the size corresponding to the circumflex artery, do a low pressure dilatation without my balloon going too far in, just to separate out the struts. And this is basically to reposition the carina and to reposition the struts. And you can see the struts have cleared up very well. And when the struts have cleared up, you can see the angiography looks great. And I hope I have not done any damage to this area at all. So there are certain types in certain anatomies you might need to do this, but it is best guided. And then once we do that, you can see that my IBIS shows that the origin is quite clean. This is a pullback from the circumflex, and you can see it's a beautiful pullback which opens up, and there is no restriction, there's no dissection planes. Hopefully I've not caused any trauma. This might be an important point to stop and take a discussion, because I know in this varied group, a lot of people might do things differently. And I would love to hear your views as well.
The struts across the mouth of circumflex. Today, you feel you left one strut across the mouth of the circumflex, and it will get covered with some growth on it, and you'll have two openings going towards circumflex. Secondly, if you have to do another angioplasty to circumflex, say after 3 years, your access to the circumflex becomes very difficult. You're going through one of the narrowings at the mouth of the circumflex. So at that stage, to push the strut aside is probably not a good idea, because there is a gap of three years. The stent has very well settled, and at that stage, pushing the strut aside is not a good idea. So I would feel if there is a clear strut which might obstruct the future access to the circumflex, and you will have to push aside the strut when you do it after 3 years or 5 years, that time you're not dealing with this circumflex artery, you're dealing with the left main, but you want to deal with the distal circumflex. So that time to address that strut is not a great idea. So I would probably feel that if on imaging, if you have a strut clearly going across the middle of the circumflex ostium, I would get it aside.
But that would be at the cost of some trauma to the left, to the circumflex ostium.
No, as Kirti showed, don't go deep. Just be at the mouth and get it aside.
But my problem is that I think the jury is out in terms of data. So therefore, this is a very hot topic to discuss, because while the protagonists of this kind of a technique are talking about the access to this artery, the people who refrain from doing it are people who kind of are hesitant to cause any kind of barotrauma to the origin or the ostium of the circumflex artery that may result in an inadvertent ISR because you did it. So the problem is the difficulty of a future procedure versus the ISR that you may have contributed to is something that would have to be studied.
No, Kirti, you have to look at it this way. If it is going to cause you trouble to go across today, it is going to be more trouble when you try and cross it at end of 3 years. So to address a lesion which you are not likely to touch, like you want to do a circumflex angioplasty, and now you're sort of pushing strut aside at the left main distality or at the mouth of circumflex is not a great idea. You're touching a very quiescent area with no ISR, and you are just touching it to get an access, which I feel is not a great idea. So I would get the stent strut across the mouth of circumflex aside.
There was a gentleman who had raised his hand. Do you want to unmute and ask the question?
Yes, sir. This is Dr. Abhijit. There was always traditional teaching that the possibility when you dilate the side branch touch only with the balloon, the possibility of distorting the opposite side of the stent is always there. So we tend to again post dilate the main stent. I mean, how frequently do you see that distortion in the main stent on the opposite side of the ballooning?
So it is and I'm going to show you a case where something like that happened. And so if you're just patient enough as we go through this, I'm going to show you.
But do you feel like after dilating the side branch, do you feel the main stent has to be dilated again to make it straight?
So more than just sometimes the deformation that you cause in the main branch may not be correctable by just a dilatation. Because what you're doing is when you're doing a side branch stent, you're pulling certain struts because you cannot be sure which window of the strut you entered the branch. And suppose you're close to the carina, then very likely that you will, the closest struts or the ring you will pull into, and there'll be an area of exposed area in the main branch. And no amount of redilatation of that area is going to cover a strut back into that area.
Right.
No, Kirti, I would feel if you're addressing the side branch with a balloon, you must have a balloon in the main branch.
Main branch, yes.
I would not suggest that you dilate only the side branch just to get the strut away. You must have a main branch stent, because any dilatation towards the side branch will pull the stent from the roof down in. And that's why you must protect that with a balloon, maybe low pressure.
Does it mean that you need to conclude with a kiss?
Yes. But don't take the side branch balloon deep in.
Yeah, without
just keep it at the mouth.
It means like a mini kiss you are talking.
So the problem with the mini kiss,
specialist in kiss.
Yeah, means a mini kiss.
So when you have two balloons parallelly in the left main, I think we distort this. So, I think there are many ways to bell the cat. The question is, what is the right way? and what is the most cost-effective way without having to pay a heavy price will have to be a part of a very cleverly done randomized control trial, which is actually by Akasuka is doing that in Japan right now. They're looking at 600 patients, and hopefully we'll have some data. But there was, I think, somebody else who raised a hand, wanted to ask a question as well.
Okay, this is Dr. Nilkan Karandikar.
Hi, how are you?
Hi, Kirti. We just interacted about 10 days back about a difficult case of mine.
Yeah.
And I'm very happy with your guidance and help. Well, what I wanted to ask you about just now is about the landing zone. Right in the beginning of your talk, you showed some excellent cartoons.
Yeah.
And the landing zone in the LED, I was looking at that. And the landing zone you showed at 10% or maybe 15-20% of plaque. I wanted to ask you, would you like to go a little distal? Can you show that cartoon again, if you don't mind? The first or
yeah.
And
He's
in that
asking, Dr. Karandikar is asking healthy to healthy, correct?
healthy to healthy, yes,
Healthy to
Right.
healthy.
yes. And in
So,
that cartoon,
And Kirti, on the same note, if ostium of the left main is not involved, and the left main is say 10 millimeter long, would you always bring the stent back to the ostium?
So if you look at my next slides, the next 5 slides, we are going to answer exactly this question about how far do we get the left main stent back, and do we cover all ostium in the left main is the big question that everybody seems to ask. So I think I'm just going to, so I'll do 2 things. First, I'll answer Karandikar's first question, which is I'm going to take it back to the first cartoon. Is that the cartoon you want to see?
yes. Now,
Yes.
Kirti, this LED, that brown bar which you have shown,
Right.
you can see that it is at, there is some bit of plaque over there.
Right.
Now, how about going a slightly distal to that
And
totally
going into a normal
the
segment of
artery?
an artery.
Huh?
Okay. To going into a normal segment of an artery. Is that what you're asking?
Absolutely. Yes, that's what I want to ask you.
So this is an interesting case. Is we analyzed some of our data and we looked at 250 consecutive left mains which were not significantly narrowed. That means we looked at left mains which had less than 30% plaque, okay, 30% stenosis. That means we considered angio, or we took normal left mains. And these are patients which underwent an angioplasty for the circumflex or the LED. And we looked at these left mains. And believe you me, that the data shows that up to 36% of plaque burden, there is no indentation of the lumen. That means the luminal area in the distal left main is the same as the luminal area of the proximal left main, in spite of there being 35% of plaque burden in the distal area and no plaque in the proximal part of the left main. Which
the plaque burden is measured by IVUS?
Yeah, the plaque burden is measured by IVUS. Yes, and I can actually share you some of the data, but it is going through publication to the Asia Interventions. This is a single center data, and I would be happy to share that data with you at all. But I'll have to get published.
Maybe we'll have to invite you again one more time.
This is great information, Kirti.
So up to 35% when you have plaque burden in the left main, remember that your left main lumen is not compromised at all. Therefore, it is safe to land your edge of your stent up to 40% of left main plaque burden, because that is normal reference area of the lumen. That is what our conclusion, that is what is being practiced worldwide as well. Now the question is, do we need to come to a normal segment of the artery? No, because as you go to the normal segment of an artery and try to land stents in a normal segment of the artery, the intima is a one single layer of intima, and you are very likely to injure that artery over there. So in fact, it is preferable to land the edge of a stent into an area which has some plaque, So it protects your media from damage, because if you put your stent right in the normal segment of the artery, even a little bit of overdilatation, you're going to disrupt a little bit of the smooth muscle, because there's only one internal elastic in between. So if you have a little bit of a cushion of a plaque in between, I think it is a better thing to have.
Yeah, this is
In a left main, when the size is 6 millimeters or 6.5 millimeters, and say it's a long left main, and say it's a 6.5 millimeter left main, and say there is plaque in the distal half. Now the problem is, do we need to have a 6.5 millimeter balloon? No. You don't need to extend your stent beyond a luminal area of more than 5 millimeters at all. Because beyond 5 millimeters, expanding the stent in the left main has no additional value. And even the European guidelines say that you should land your stent in a left main, in a long left main, even in an area where even if there's plaque, if you can get up to a 5 or 5.5 millimeter dilatation, that's enough. You don't need to go to 6. That is another very important lesson to learn. And those are the reasons why I don't like to come to every left main ostium, because it makes a future angioplasty a little more difficult, because your guide catheter is very difficult to engage.
This is great information, because, Kirti, till now the standard teaching has been go from healthy to healthy or normal to normal. But what you have just now told is really very valuable information, I must say.
Thank you. But this is my data. This may not see. I mean, you have to remember one thing, that today what I'm talking about is something that I have learned and I practice. Now, if you look at Sirish and yourself and people like you who are doing left mains, you all will have so much more experience than I have. I mean, Sirish has done 600 left mains from 2000. That's a huge number. And of course, his experience builds into this whole thing. So eventually, we will have to work on a common ground between all of us, putting all your ideations together. But in that, there will be some general guidelines which we'll all have to follow. And of course, there'll be some variations. Nothing is 0 and nothing is 100% in cardiology. It is always in between. So there is no clear cut black and white. It is almost always gray. The question is how gray it is. And we are just trying to decipher those areas. So coming to, should we extend every left main stent to the aorta ostium? And now let us look at this aorta ostium. This is a shaft. You can see clearly that the distal left main is involved, the ostial LED. So we need to cross over. Circumflex origin looks good, but we might want to kind of come back. Yeah, Karandika, you want to ask another question? You have another question?
No, this is, very interesting. I just want to tell everybody something very important about you. I wanted your opinion, and you asked for the angiography and the plasty on internet, and you even sent me the software. Thank you for that. And your opinion came back bang in time, and the patient has benefited. We'll discuss that case some other time.
Thank you, Karandika. Thank you, it helped. But anyway, let's get back to this. So let us look at the IVUS image at the ostium. And this is the IVUS image at the ostium. Now, when I look at this ostium, I can see the media all around. Can you see the media is all around? There is a sliver. There's only a thin sliver of plaque from 2 o'clock to 4 o'clock. Now, because of the eccentrically placed IVUS catheter, sometimes because of the wire between penumbra, it is not possible, but you can imagine pretty clean left main. So there is no need to come back to this ostium. You can find a safe landing zone within the ostium and spare the ostium of a stent in this patient. And this is a very, very important lesson to learn, because this will help you engage the left main in the future much better. So this is one.
Hello.
Yeah. So, okay. This is a second. Now here the left main is approximately 12 millimeters long from the ostium. And you can see that when I come close to the ostium and just outside my guiding catheter, look at my left main. The area is 8.2, which means that one of the diameters is probably 3.5 and the other is maybe 2.5, very oblong. But look at the plaque burden. It's a large plaque burden. This is a very large artery. The artery is 1, 2, 3, 4, 4.5 millimeters and 4.5 millimeters. So the ideal the area should have been 15, but this is 8.2. So this is a reasonably compromised lumen, which is slit-like. Here, it is best we come back to the ostium, because if we don't come back to the ostium, if we try to place a stent anywhere close to this distally, it is going to cause an edge trauma, which is going to come back and bite you at the ostium. So this is no question that we need to get it back to the ostium. And then the last picture is here, where the ostium is less than 10 millimeters away from the carina. These are what I call the short left mains. In a short left main, we have no choice but to extend it to the ostium. So we are, because of lack of choice, we have to do this. But at the same time, when there is a calcified, this is not a nodule, this is a protruding calcium which is eccentric in the left main like this. Remember that whatever you do, and even if you extend your stent here, the area that you create will be like a D. It is not going to be circular, because these calcified areas which are eccentric are very difficult to make a perfect circle of without having a rotational atherectomy wire completely embedded over here because of bias, and then you kind of take it, or an orbital atherectomy will be a better thing to shave it off. Sorry, there's another question. Go ahead. Somebody has a question? No? Okay. So, extension of left main stent to the ostium is based on the proximal landing zone in the left main of less than, but I would say 40% left main plaque burden is a great plaque burden to have. And if you have 40%, just land your stent in that edge, as long as it's not a thin fibrous cap, it is not a very less, I mean, it's not a dark echogenicity that are a necrotic plaque or anything. As long as it's a fibrotic area, can land your stent. In a short left main, inadvertent coverage of the ostium is required. In a large left main diameter more than 6 millimeters, land a stent at a luminal, which is 5 millimeters is enough. You don't have to extend beyond it, and you don't have to have a 6 millimeter balloon in your room, because this is good enough. And if no plaque is there in the left main under the entire thing, try not to stent that left main. Try to park your stents in a very large left main. Try to park your stent in the ostium of the branch, either in the LAD or in the circumflex, and it's okay to have a strut or two hanging across. So having said that, I can now stop. And Siddhish, would you have any comments to add to this in any way?
I mean, give it a thought. Those who are not using IVUS on regular basis in their cath lab, what is your suggestion if the left main is short, something like 10, 12 millimeters?
I think then we don't
cover the ostium or not cover the ostium.
So if the left main is very, very large, if it is a very large left main, even if it is short, it's okay. But if it is a left main which is 4 and 4.5 millimeters in diameter, then I think we don't have a choice but to come to the ostium. I mean, how do we complete that procedure? Because it is impossible, probably. You and I both know we'll struggle till the cows come home and we won't get the right position. Better to come to the ostium and then plan this procedure. Short left main.
I think if you cover the ostium, it gives you an opportunity to really dilate the entire length very aggressively.
Exactly.
And if you miss the ostium, let's say there are times
when you don't have to worry about.
No. I mean, there are times when you want to cover the ostium, but the stent moves in, maybe get pushed by the guide catheter as you're slowly inflating. And if you miss the ostium, I don't like it at all. So I think when I decide to cover the ostium, I think I clearly have very defined steps, like guide catheter should be away from the back end of the stent and quickly go to about 4 and then slowly to whatever you want. And then make it float in the aorta, half guide catheter, and that is how you can really stretch stretch it with the stent balloon. See, this is a preparation in case because you're protruding into the aorta, your next guide catheter position may not be the best, and the next NC balloon may not go in easily. So I think try and complete. I always do it for side branches, like LED diagonal. You put a diagonal stent, I pull back 2 millimeters, go high pressure, in
Exactly.
case if we cannot cross into diagonal later. So I would probably do the same thing for left main.
Absolutely. There's some more other question which was there in the background. Yeah, go ahead.
The only concern about coming to the ostium is, many times you may come into the aorta 1 or 2 millimeters. That makes the angioplasty even more difficult. Getting right catheter in, getting the other stents in, and maybe doing angioplasty at a later date. So many of would rather shy away from the ostium and keep it slightly in, so that the angioplasty is easier. In getting these stents further down and doing angioplasty at a later date. Because if you don't come up to the ostium, if you're not into the aorto-ostial area, say 1 millimeter, then probably you're not covered the ostium adequately anyway. If you're not doing
exactly.
Don't worry about the next guy. You leave it to him, That's his headache, not yours.
I like that. That is a great philosophy to have. Yeah. Let's move ahead. Okay. So now we've done our angioplasty, right? Now, what are we looking at? How do we assess a result? So this is a cartoon which helps me think how to assess my results of the angioplasty. I've just put some random numbers, but these are just numbers that I look at in terms of, so again, now we have these two zones. The brown zones are the landing zones or the edges of the stent, which we have 3 edges of the stent. One will be in a bifurcation region. It's going to be the edge of your circumflex, the edge of your LED, and your edge of your left main. Now we have to make sure that you go outside the left main, outside the area of the stent, and look at the reference luminal area here. So just outside the edge of your stent, what is the reference luminal area? That luminal area should be the stent area in this terminal region. And if this terminal region is 10 millimeters away from the ostia, then that is the area that you should aim for through the length of those 10 millimeters. If this is more than 10 millimeters, you make sure that you factor in a gain of an additional 0.3 millimeters of diameter related increase in the area. So essentially, what you're trying to do is the edge of the stent has to match the area which you're parking your stent inside so that there's laminar flow. For example, if this is a 3.6 millimeter luminal diameter, then the area is going to be 9.6. So if I put in a 3.5 stent, then I am aiming for a 9.6 luminal area. The reference vessel diameter could be 4.4 and the reference vessel area could be 15.6, which is okay. But what you're aiming at is just 9.6, and that's what you want to achieve at this edge. As you come forward, what is the lowest that you can accept in this 9.6 area landing zone, assuming that this is just a 10 or 15 millimeter deep left main stent, LED stent, is you should be able to get at least a optimal expanded stent IVUS wise is 90% of this MSA. If you get it between 80 to 90, then it is a little suboptimal. But if you get it to between less than 80% of this 9.6, that means you kilometers of 7.5 and less would be an under expanded stent at the ostium of the LED or anywhere within the length of the LED. Is that clear?
Why are you willing to accept ostial diameter or ostial area less than distality, end of the stent? I would feel that ostial diameter should be clearly bigger area compared to a end of the stent diameter or area.
But sometimes, Sirish, that is not possible. And I'll tell you realistically why it is not possible, because this is the area where the core image, the plaque is most dense, and you might have the highest amount of calcium. So you might be in a 10 millimeter area, you might achieve an area which is slightly bigger distally, and therefore you don't overexpand it too much. but you may struggle to get even 9 millimeters over here. And so if you actually measure your ostium LED may be a little less than your edge of your LED. And that is okay as long as you are within that 80% or above 80% thing. Can I take one emergency call if you don't mind? It's from the EMS.
Yeah,
I'm
please.
sorry. Yeah. Hello, Neeraj.
Rajiv, I would feel
Yeah.
the LED ostium is one area where I would not compromise. I would
Right.
prepare it in such a way that the LED ostium is clearly bigger cross-sectional area as well as diameter compared to the end of the LED stands, which could be 15 millimeters away. I agree with Kirti's point that that is one area, the ostial LED or ostial circumflex. These are the two most difficult areas to stretch fully. So every time I have ostial lesion, I would probably use a cutting balloon or some kind of ablation.
Right, what I wanted to ask Kirti and you also is, many times we come across lesions, for example, which are just ostial. Say you have ostial circumflex lesion, significant. The LED ostium is paired. In this situation, what is the strategy?
I'm going to show you that. We're just graduating to that level now. So
Right.
here we have, so this is a reference point that what you need to do is look at the reference vessel area. Just one moment here. Oh God, okay. Hello. Hello. Oh God.
Kirti, one of the reasons why when we are doing an ostial LCX or ostial LED, we always like to bring the stent back to left main is we can get a good stretch at the site of the ostium. And I would probably feel that every time you do critical ostial, you should bring the stent back a few millimeters into left main.
The only caveat to that, where I would say that try to do sorry. Yeah, Rosanna. Yeah. Yeah, I know, and I'm trying to call him back as well. So I'm in the clip. Okay. I'm discuss it now, please. I need 30 seconds to just clear up this emergency. Yeah.
NG, what do you think? In pure ostial lesion, you bring the stent back to the left main many times or not many times?
No, in fact, I would agree with you that, if you don't come back to the left main, if you just want to stent the LED, there are a lot of instances where we miss the ostium. And, then you lose the entire purpose of doing the angioplasty. And if there is an ostial lesion, and if you really want to dilate it, and as we all know, at the ostium, the stenosis are more difficult to dilate. The elastic fibers are more dominant, maybe. And therefore,
Yeah, I
I would
entirely agree with you,
back
NG,
at
that
the
the ostium has to be prepared aggressively, prepared
Yes.
very well before we take the stent.
Yeah, and if the left main is healthy, one should come back to the left main and go across the ostium of the LED if it's a tight lesion. I would agree to that point of yours.
I think Kirti is ready. Let's go back to him.
So basically, once we do the brown edges over here, the blue areas are very important to assess our results. And I think this is where we look at our minimal stent areas. And what Sirish was saying is the ostium of the LED, the ostium of the circumflex, and the distal confluence of the left main. These are the areas where you just cannot afford to shy out on having a less than optimal stent expansion. And this stent expansion should be the operator should make it his business to assess the lesion well enough before he even, oh God, sorry about that. Hello.
Kirti,
Hello.
I would also feel it's a part of lesion preparation. I think all ostia, including say diagonal origin, they probably need a different kind of preparation. And since LAD and circumflex and the distality of left main are the blue bars you have shown are very important locations, and they have to be specially prepared for a good stent expansion and good.
So how do you know that your
area.
stent is, how do you make yourself know, okay, now I'm ready to put my stent into this place? So I think one of the things is if you do not have IVUS and you realize that your ostium of your LAD should at least be 3.5 stent, and that means your area should be at least 9.5, because a 3.5 stent is going to be 9.5 millimeters area. Then it is an important thing to take a 3.5 balloon here, go up to 8 or 10 atmospheres, and make sure you look at it in two fluoroscopic views that that balloon is completely expanded. And if it is not expanded, then you are going to have an unexpanded stent as well. So that is a poor man's way of making sure that your region is prepared completely. Yeah. So I think that is important. Of course, you have to look at edge dissections, appositions, making sure there's no malappositions and things like that. And you've got to make sure there's no tissue prolapse as well. And there's no residual plaque burden. A residual plaque burden is you do angioplasty and you see your stent area is 8, but your vessel area is, say, 17. That means your residual plaque burden is 60%, which means that for some reason you have undersized your stent or you've not assessed your artery completely, because if your residual plaque burden is high in spite of having an optimal expansion, maybe you did undersize the stent. And I think that is relevant when I see a lot of people putting a 2.5 or 2.75 stent in the proximal LAD. And then it is very, very difficult because the angiographically may look good, but IVUS wise, it's unexpanded. Okay. Of course, we all know the Kang's law, and the Kang's law is that the predictors of ISR are the 5, 6, 7, 8. That means when you have 5, 6, 7, 8 in these areas, then they are going to predict instant restenosis. The goal of patency is much higher than that. And that has to be individual arteries will have been. This is not a good rule for all generalized arteries. Each artery is based on its size. So to obey this rule, what one needs to do is that you need to have a fully expanded 3.0 stent at least in the circumflex ostium, a 3.5 in the LAD ostium, a 4.0 in the left main, and sometimes even a 4.5 in the left main. And these are important rules to remember if you have to accomplish a great bifurcation LAD a bifurcation left main angioplasty. This is a question that was asked, like what happens? How do you deal with an isolated circ lesion? So this is an isolated circ lesion. The LAD looks great the LAD looks good angiographically into the left main. And when you look at this lesion, it looks like a 001. Calcium is moderate to severe. Angle is 70, 25 millimeters or less, or more than 25 millimeters of plaque in the circumflex. And these are the sizes. What is the plan? In the calcified lesion, I would do a rotational atherectomy going into the circumflex. And once I do a rotational atherectomy, I'd use a flextome, or if there's circumferential calcium, I use an IVL. But the whole idea is to prepare that lesion maximally so I have complete expansion of that stent. And now I do a pullback from my circumflex after the rotational atherectomy. And what do I find? If I find that, okay, this will tell me the landing zone, the distal ones will tell me the size of the stent that I need. But as I come to a branch, I know that my size is going to go up, and you can see that my sizes are going up over here. They're not the same as what it was in the branch. So I know that this is my size of my circumflex, which is fairly roomy. But what is important is when I see this ostial image, I can see that the carina has some plaque, which is calcified as well. And opposite to the carina, there is a calcified area, which with a area of not more than 2 millimeters in spite of the rota and whatever the balloon dilatation you might have done. Let's look at this more relevant. Here is your circumflex origin, and this is a plaque in the carina, and this is your LAD. Now you have done a rotational atherectomy, and the opposite side of the carina is an eccentric calcific plaque. You have taken and you say that you want to get at least a 3.0 balloon expanded to put in a 3.0 stent. And when you expand this balloon to 3.0 millimeters, what you've done is you've taken the carina and you pushed it into the LAD. When you push it into the LAD, and now say if this was a stent, you permanently put it into the LAD, you have compromised your LAD lumen. And this particularly happens when there is a calcium on the opposite side of the carina. And this is a very, very important thing because we don't look for it. So calcified eccentric lesion on the opposite side of the carina is very likely to cause you carinal shift, and your branch is going to be compromised. And that is a rule. So when you look at this left main now, the circumflex, this is the distal left main IVUS. This is your ostial circumflex, as I showed you, calcium on this end with a thick carina. And this is the LAD. Even though the LAD per se is going to be FFR negative, maybe with a 4.6 millimeter square, but in this calcified lesion, once you do a cutting balloon dilatation with a 3.5 millimeter balloon, you will push this plaque deep into the LAD, and you will have now compromised this LAD. And I'll show you an example of how that has happened. And therefore, in a calcified lesion, when you see these kind of borderline MSAs or MLAs, you need to make sure that this is not a 0-0-1, this is a 1-1-1, and this will require an elective 2-stent strategy. And therefore, this is what we did. We did a culotte in this case. Does this resonate with your practices as well, or is there something that you would add?
No, absolutely. I think I would be very reluctant to leave ostium of LAD uncovered.
Yeah.
Like every time I stent left main and circumflex, I would be very pro LAD ostial stenting. Not the reverse.
That is
the reverse, if I'm doing left main to LAD, and if I can leave circumflex unstented, exactly. I would.
Threshold to stent the LAD is high, whereas the threshold to stent the circumflex is rather low when we do these cases, isn't it?
The future is not very good, circumflex stent.
Exactly.
That's the reason.
Exactly. So let's move on. So in heavily calcified lesions, my threshold to convert to a planned 2-stent strategy is very low, because in calcified lesion, a provisional stent strategy, if you decide that now you have to stent the LAD, it is too far gone to be able to prepare the LAD completely to your satisfaction. So therefore, you should have a low threshold to convert it to a 2-stent strategy. And therefore, complex, as it becomes more complex, the rules of provisional versus single and several can get a little diluted over there, I think. So these decisions were based on IVUS on finding. So when the second branch has a large area with a low plaque burden, when the plaque is on the opposite side of the carina, or you have a plaque which is very, very soft and does not extend more than 2 millimeters into the ostium of that branch, or if you have an area which is like this, where again, it's a very stable plaque with a large area, in this LAD case that I showed you, these are the kind of lesions. So plaque burden of less than 50%, MLA of more than 5.5 in these areas, and plaque away from the carina, and a soft plaque limited to ostium alone. These are areas where a single stent strategy is very likely to work, as long as you make sure that your circumflex does not get compromised after the stent. You make provision to make sure it doesn't get compromised prior to putting your stent in. That is important, because once you put in your stent and then you try to open up circumflexes, you're likely to compromise or deform your LAD stent, which is a very important step. Yes, any questions?
I mean, when you say all this, are you talking of the diameter of the stent, which is going from left main to LAD?
When I'm talking about all this, means I'm talking about MLA.
Yes.
I'm talking about the naive MLA of the circumflex osteo before we put the stent in. So this is a preliminary pre-investigation, pre-PCI assessment of the circumflex osteo.
So the decision, 1 stent or 2 stent, is pre-decided, or sometimes afterwards also?
Many times it is pre-decided here. So when I look at, like, if I were to see this kind of an origin of the circumflex, then I know that I'm not going to stent that circumflex. If I see this particular LAD, when I saw this LAD, I knew I didn't want to stent this LAD, and this patient did well. Even after 5 years, the ostium of the LAD was not compromised. I had to do it. So essentially, this kind of a plaque distribution in the, say this is the LAD and this is the circumflex, these kind of plaques are very forgiving. It's this when you have circumferential plaque on the circumflex and you have an eccentric calcium on the one of the edge, which is opposite carina. That's when this plaque is going to compromise this area very well. And this is a little less forgiving. And here you're going to think of bifurcation strategies or two stent strategies. Here you can get away with a single stent strategy long term as well, I think. But this is something that needs to be tested. It's just it is what I infer, and this is how I base my practice basically. I've showed this case. This is a very important case, and it's like when it gets more complex, how do you decide? And of course, calcium helps you decide. A CT scan will tell you which are the calcified areas, and here you can see that the circumflex is densely calcified, so it is going to require a rotational atherectomy. The LAD is eccentric calcium, so it will require something deep preparation. The left main, you can see it's very densely calcified, the distal left main. But the ramus is relatively fragments of calcium, so they are very forgiving and you don't need much, but you'll have to purely see how they work. So after doing a rotational atherectomy in this patient, our whole areas were how do we, these are the red lines are the areas which are decision-making IVUS images. So the landing zone, for example, this is a 3 millimeter artery and this is a 2.7 millimeter artery here. So again, both these arteries are important. You can't leave them alone. When you come at the branch points, I told you, when you have significant branches, anything you do in one branch will affect the other. So here, I think whatever you do, you'll have to kind of save both branches. You cannot afford to have to lose one branch when you're doing this angioplasty. And the same comes with the left main as well. That this is the ostium of the circumflex, and the lesion is and you have a very small circumflex before you have a branch. So you will have to consider these as two bifurcations in tandem, and that is exactly what we did. Now, when we look at the angiography, you say, oh, this ramus looks quite okay. Why do we have such a long stent? Why can't we take a shorter stent? When you take a shorter stent, you look at the IVUS, you see that the IVUS, the plaque burden is very large and it's eccentric. So if you were to take this as your landing zone, then you would end up putting a 2 millimeter stent here, whereas you go here into the distal and you can say you can still get away with a 3.0. So finding a good landing zone to be able to put in a good size stent is very important. And sometimes you may end up putting a slightly longer stent and that's okay. But putting in a smaller stent, I will show you in an example, is quite detrimental to the patient sometimes. So here, that's what we did. We actually made this choice. And then we looked at the LAD and you can see that the LAD pullback, as you came over here, you can see the LAD eccentric calcium, more eccentric calcium. And in the left main, you can see there are two folds of calcium, which are opposing layers of calcium. Now, if it was only eccentric, it wouldn't work. But when you have a support of calcium on one end and you have calcium on the other, here is the area where if you find any inexpansion of this sort, then the IVL will work and IVL will fracture it. And here you can see the fracture from the IVL shockwave, which is well demonstrated. And you know that now you are ready to implant your stents. So I think it's important. So preparation of all these lesions is good. And then we put in our stent strategy was first stent, we do a pot, then we do a second stent. So then that's our first stent. Then we put in our pot and we do open that strut of that branch. You can see we open the strut and then we are putting our second stent from the left main into the OM. And then similarly, we do a pot of this with a large balloon opening up. And then once we have done that, this is our pot for the proximal circumflex. And once we've done that, now we have set it up with a pot 4.5 at the left main. And now we're putting our third stent over here. Now, this patient has done more than 2 years, is stress negative completely, and very important that we look at the final images in terms of what results we've got. Everything looks good everywhere except that the ostium of the circumflex, still the plaque burden is very high. So even though I did whatever I did with the 3, I knew that my circumflex, my area of expansion over here still can be improved. So we went and we further dilated the ostium with the 3.5 with a balloon at a very and that I say, and this is crucial because when there's a very small chance that you may have compromised your long-term result. And this is a result, and of course the IVUS result is we walk around 8 kilometers per day now. Any question on that strategy? I think it's almost 9:40. A lot to go. I mean, I'm happy to stop anywhere. If there's any specific issues, I can specific case and take it on from there. Maybe uh, an interesting case, one of the interesting case that I thought I could discuss with you all was uh, here. This is a very important case because we often see something like this. So this is not a left main. This is a circumflex OM and this is a circumflex lesion. The operator decided that he's going to put these two stents. So he took in two stents, a 2.528 in one branch and 2.523 in the other branch. He did a classical crush. He put in the stent here. He deployed the first stent. He put in our second stent, put in the first stent. Then he put in our second stent to the ostium, pulled it out. And then he did a kissing balloon. But there were, in the angiography, I never saw any pot being done. Maybe he did it, but I couldn't see it being done. And this was his final result. And when I look at this final angiographic result, I really like the result because angiographically, it looks fantastic. This patient came back in 10 months. So why did this patient come back in 10 months? And what happened at that time? You can see that the OM is completely narrowed. The circumflex ostium is narrowed. When you look at the ostium of the LAD over here, it looks clean. It looks clean. But here, the ostium of the LAD looks a little hazy. So is the distal left main looking hazy. So this is how the stents are oriented. In this patient, what did we do? We ended up doing an excimer laser into both the branches. And when we did that, the most important is what happens now. So here is the QCA, and the QCA shows that it's 50% narrowed. But when I do an IVUS, you can see that the MLA at the ostium of the left main, and you can see the circulars, is around 3.5 millimeters square with a 80% plaque burden, which is very, very soft and a lot of echo-lucent areas. So this is important. Now, this important image is very important to put into perspective because now this is the distal circumflex, and you can see that the size of the stent is a little undersized. For the 3.2 artery, it was a 2.3 millimeter stent. The stent is deformed in terms of it's become oblong. One axis is much smaller than the other at the level of the bifurcation in the ongoing circumflex. The circumflex, again, the landing zone was not, so you can see that this is a 6.5 vessel area. So it's more than 2.75 millimeter artery. And the landing zone, there is an area at the edge of the stent is still 2.9. And you can see it's a 3 millimeter vessel. The stent is just 1.8 at the circumflex OM origin. And at the circumflex origin, you can see it's a 3.5 millimeter artery. And the stent is barely made it to 2.6. Over here, sorry. It's 2.2 in a 4 millimeter reference vessel in the circumflex origin. So we have underexpanded stent, late malapposed, we have deformed stent, underexpanded, all the recipes of what was going to be a restenosis. Now, our current assessment is that the LAD is 3.5 lumen. Our left main is large, plaque burden is less. So yes, but look at the LAD. This was probably angiographically not there. And you have seen plaque has started in the distal left main as well, probably from the trauma to the left main at that time. And very important now, let's put it the circumflex origin right here. A 5.2 millimeter square, thick carina. And thick carina over here as well. You can see that there is a circumflex is right here. The wire is right here. Now, when I start dilating this lesion with a 3.5 balloon, I want to know what is going to happen to this. It is 3.5 right now. So we say, okay, let's do a cutting balloon. We do a cutting balloon at this. We put in a cutting balloon and a drug-eluting balloon in the circumflex. We do a cutting balloon at this level. And after we've done a cutting balloon with 3 at a high pressure, this is what we see. We look at this LAD, and this was 53% QCA. Now this has become 70%. So when we look at the IVUS images, we realize that this IVUS has really made this 2.5 millimeters square after this dilatation. So there's no way that I can now do this bifurcation lesion without incorporating my stent into the left main. So the left main has become an integral part of an angioplasty because of the trauma of a previous stent in a circumflex. And that's how this has to be looked at one lesion. Whenever we do OMs and circumflexes, we cannot ignore what is happening in the left main. So here I parked a 4.0 Wolverine in the LAD and I put in a 3.0 millimeter long stent into the OM branch. And there was a drug-eluting balloon which was in the circumflex. I expanded it and then a 3.5 pot at high pressure. So fully expanded it. And once I'd done that, I crushed it with a balloon with a 4.0 the Wolverine. And once I'd crushed it with the balloon, we did a kissing. Then we put in our stent into the LAD. Our first kiss, a stent into the left main to LAD. And once we did that, we did a 4.5 millimeter pot at the end, and we did a kissing balloon. So having done this, this is the result we got. And these are the MSAs from the LAD and the OM and the LAD. And we've got a fairly good result. And now this patient is approximately 13 months out and is walking around 7 kilometers without any issues. His last restenosis was within 10, his symptoms started at 3 months. He presented to us with a little bit of raised enzymes at 10 months after the initial procedure. Any questions on this?
Kirti, this is outstanding.
Thank you so much. It's a big honor when this comes from you, who's so far more experienced than I am. I think I take this as an honor and a privilege to be here. And of course, yeah.
Whenever there is an ISR, we need to think totally differently. Like in this case, you spend so much time and effort thinking what to do to LAD.
Yes.
So I think that is very important when we think of long term in this kind of difficult thinking case.
I think we need to put it all in a drawing board. We need to think of this like an architectural plan where we think down a board and then decide what is going to be the best long-term thing. And everything that I'm showing you over here, I discuss with as we go along the case. I've presented this case many times, and you can see that, we've done distal left mains where we've done ribuses, and we took standard balloons and realized that angiographically it looked great. IVUS wise, look at this. It's not even 3 millimeters expanded in spite of putting 4 millimeter stents. And can you see the plaque prolapsing within the stent struts? Naturally, this patient came back because what we had done is we expected, this was our expected MSAs, and achieved MSAs were so far poor compared to this on the IVUS that this was bound to come back. And then we changed our strategy where this lesion is the one which actually helped me do that. Because I thought, and we say, oh, Rota, I'll do a flextome or a NC balloon is good enough sometimes. And you do a dilatation, you put in a 4.0 stent. It looks great. You think there's a great result. Though angiography, there's a little bit of a recoil. And this patient then comes back because this is your strategy, comes back in 8 months with the ISR. And you say, what went wrong? And then you say, okay, you do a rota. I did a 1.5 and a 2.0 rotablator into that circumflex. And then we put in a 4.0 stent again. And this time we got a complete expansion. We lost a small side branch, but that was okay. But what is important is we did an aggressive rotablator. What is the difference between these two images? Very subtle. But the important message is the change in MSA. We used a 4.0 stent here. We got a cross-sectional area at 4.5. We used a 4.4 millimeter stent here. We got a cross-sectional area of 10.2. This is the difference between a good long-term result and a bad, poor short-term outcome. And I think this is something that IVUS is going to point it out. And we need to make sure that we don't trap ourselves in the left main space with small cross-sectional area. Also, when you have this, you see crowding of struts in one side, whereas over here you'll have even distribution of struts in your circumferential. And so you not only cause deformation, but you cause what is called as a transsectional deformation, where you crowd all your stents on one side in a calcified unprepared artery, And you can see that a lot of the struts are overlapping or stacked. Therefore, I call it a deformation. But this is what taught us that we have to do aggressive preparation for our left main. And therefore, now I very often go to a larger burr before I do anything. And this is before the times of the IVL. And we were able to then meet our expansion limit. So we got what we wanted in terms of what we defined and what we got. And how do we define this? Suppose we are putting in a 4.0 stent in a LED, then we know that 4.0 means 12.5 has to be. So it has to be a 12.5 square. So that becomes your expected, and your actual is this. And if it is 85%, you're okay. But if it is less than 70%, you're really not done a good job. And I think that's going to be what is going to decide the outcomes in your left main angioplasties. I think what I can go on and on and on, but let me stop here because there's a considerable amount of, but I'll go to the very last slides, which are important. That for these calcified lesions, of course, we have an aggressive rotational atherectomy. We have these various tools that after we do that, we go to the next level of how do we expand the arteries, and then we put our stent in. Sometimes we take these high pressure devices directly if they can be delivered. The question is, can we get our stent optimally expanded? That is a key question. And therefore, these are the limitations that, burr sizes are limited. Most of us use 1.5. Very few people use 1.75 or 2.0. Then we have new tools like the ELCA, and we have the IVL shockwave. How is it going to fit in? And with the IVL shockwave, at least the use of the OPN and all has gone down in my cath lab. And I think when you see these calcified lesions in the left main, a CT scan will help, but the whole idea is to do imaging, but sometimes the imaging catheter will not cross. So you need to see if your rotawire will cross. If your rotawire crosses, do a rotational atherectomy. But if it doesn't cross, then you can either use a torus or ELCA or an orbital atherectomy. And after you've done that, you still come back and do an imaging, and then you define what kind of calcium you have, and then you decide whether you have bias, whether you can expand your rotational atherectomy to a bigger size, or if it's eccentric, then you need to factor it, because if it's very eccentric, you know that it's not going to work with, you're not going to get a perfect circle. And you see if you have fractured calcium. And of course, when you have a concentric calcium, fluoxetine, Wolverine, or even an NC balloon may work sometimes, but if it doesn't, you go to an IVL. In an eccentric calcium, which is protruding, wire bias is favorable, escalate, but otherwise, high pressure balloon or flextome is my choice. And in a deep calcium, really any technology works. Over here, I'm going to stop because I think it's a long thing. It's almost closing to 2 hours. And I think I bored you all and put you all some to hope that it's been good.
No, Kirti, let us give the final comment. And I think it was really big learning for many of us, and or maybe all of us. I think the way things have changed in left main, and we are making better impact, better result, good long-term future. I think, Kirti, today you added so many different feathers to our thinking line. So really a big thank you to you, Kirti, and keeping time for us.
Thank you so much.
Dr. Rahul and Rajiv, good choice. Kirti, block your date, say 3 months from now for another talk, and we'll give you some very complex topic, and I'm sure we'll hear a lot from you.
I'll do my best to, to that level, but a lot of the things that I've said today, Shirish, I've learned a lot from my interactions with you. I watched Mark Clay perform, so many amazing tips and tricks that he has from his just vast experience. And I think a lot of you had added so much wealth to my understanding of things as well. So it's a constant exchange more than, today I've learned so much sitting here, but thank you so much for having me. Really.
Thank you indeed, Kirti.
Thank you.
It's been a pleasure.
Shall we conclude the
I
session?
know, I remember the Makle gave me a piece of his mind because I was on some trip somewhere and I couldn't attend his call. So he said, Kirti, I can talk to Narendra Modi much easier than I can talk to you. And I said, sorry, Makle, I didn't mean that at all. My phone has got jumbled up. I went to an iPhone from an Android and all my names of everybody has jumbled up. But then I saw his message and I said, oh my God, Makle called me and I have not returned his call. So very scared like a mouse, I called him back. He fired me for a minute and said, तेरे को कितना फोन कर देगा तू फोन नहीं लेता है. Thank you, Makle, for getting me on this. Thank you so much.
As a result of that, we got an excellent lecture today, and we are all the cases. Thank you very much.
Totally different level.
Thank you. Thank you.
It's been outstanding.
Yes.
Outstanding and a big learning for all of us. And we hope to have you again once again.
Thank you so much. It'll be my pleasure. Yeah.
Excellent talk.
Good night, guys. Have a great time. Go back to your dinners and I will do the same. And
no, we already had our dinner, Kirti. As we were listening to you, that's what I do.
To reach home.
My turn to home.
I'll sign off. Okay.
Bye.
Thank you very much. Yes.
Bye then. Bye.